Good evening, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. It's my great and pleasure and honor to introduce him. He is none other than the very renowned cardiologist, Dr. Ramamurthy Bengi, sir. Sir is MD in Medicine, DM in Cardiology, International Cardiologist at Bengi's Heart Care and Fertility Center. And with Sir, we are going to talk about the topic for today, which is infectious disease in heart. Before moving on to today's session, let us have a brief look on what the topic says. So, in this comprehensive exploration of how infectious diseases impact heart health and what we can do to mitigate these effects, in an era where global health is increasingly interconnected, the relationship between infectious diseases and cardiovascular health has never been more critical to understand. This webinar brings together leading experts in cardiology, infectious disease, and public health to explore the multifaceted impacts of infectious agents on the heart. And this is what we're going to talk about today. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you. Thank you very much for your courteous invitation. And as you have been mentioning it, in fact, the infections and the heart diseases are being less and less correlated. Everyone's mind is on important aspects of lipids, cholesterol, hypertension, diabetes, heart failure, and the like. Okay. And at the most, some of the cardiology people who are of general nature, they talk about the so-called endothelial dysfunction and inflammation of the endothelium, inflammation as a pathophysiological mechanism in atherosclerosis and so on. So there are so many connections between the infections and the heart. There are two methods. One is a possibility there is an infection in the body. It may be upper respiratory infection, a lower respiratory infection, a GIT infection, even a cutaneous infection, which may have an impact on the heart. And on the heart as such, overall over the contractility as well as its pumping ability, but also it can have various mechanisms, including hemodynamic perturbations of preload, afterload, and the contractility suppression, an effect on the heart itself, so that it dictates the outcome of the patient who has developed infection. When one should mark the word that these days the diseases do not come isolated in pockets. Heart disease patients do have many other diseases. Bronchitis exists with the heart disease. Asthma exists with the heart disease. Renal dysfunction exists with the heart disease, and so many other infections. Renal infections. What I mean to say, like that, there is always a connection. We do see this sort of problems frequently in our day-to-day practice. And another aspect is infections directly affecting the heart. Recently, we went through an epidemic, which we all know, that is corona epidemic, and we have noted that there are a lot of patients who did have manifested myocarditis, cardiomyopathy, and various other manifestations, sudden deaths, poor outcomes in the post-stenting problems, including stent thrombosis and the like. This is another aspect. Anyway, I will try to highlight and present to you as I go along the various manifestations like this. Now, the very peculiarity of the heart is that we should be very grateful to the Creator, the God. Heart muscle cells are somehow resistant to many infectious agents. It is not like lungs or the liver or other organs where they become easily infected with the external infectious agents. It is not. It has got an inherent capacity to resist the invasion of these organisms. This is a very peculiarity as far as the heart muscle is concerned. This involvement from the infectious agent may be direct infection. There, it may be a virion, it may be a bacteria which may affect directly the muscle cells, or it may produce an inflammation of both the muscle cells and the interstitium. So either manifestation may be there, and we do have this sort of a pathology often happening in all of the diseases. Now, the inflammation is concerned. Indirect, it is an indirect inflammation. We have recognized that it is more of the time as a sort of an hypersensitivity reaction. Heart muscle itself is standing like a bystander damage happening, or it may be an autoimmune disease happening, autoimmune damage is happening. More and more, we have been recognizing either hypersensitive reaction or an autoimmune disease damage as the problem, pathophysiological mechanism in the infectious diseases. I made an starting remark. We have been recognizing more and more atherosclerosis starting as an endothelial dysfunction, probably an inflammation, and this inflammation is where is it arising from? So, though it is happening in the coronary arteries, it is probably the chlamydial infections in the throat, particularly GI infections, Giardia, and other infections, H. pylori particularly. Gingival infections are responsible. There are a lot of papers have come up, but the the proof of the pudding is not available. If you treat these infections, the prevention of atherosclerosis and or halting of atherosclerosis is possible, has not proven. So the infection or inflammation process has got a fundamental role in our day-to-day practice of atherosclerosis and atherosclerotic related thrombotic events in the form of acute coronary syndromes. We should keep this point in mind. No infection and the heart connection is being complete without analyzing in terms of atherosclerosis, which is a common topic in day-to-day practice. As I said, the involvement may be directly, and then it produces a myocardial dysfunction and various clinical manifestations. It may be worsening of the cardiac condition. For example, there is an already existing LV dysfunction, it may become worsened. And sometimes we also see the heart diseases are coming to the forefront because of the recurrent infections that are happening. Many of us, we know that a patient of an atrial septal defect, because of the pulmonary congestion, frequently gets the lower respiratory infection. Often we ask the student, how frequently is the frequent infections and the like. The recurrent infections, the lower respiratory tract infection, often call you for the possible suspicion of an atrial septal defect. And this app also happens in mitral stenosis. Many a times we are bogged down by the pulmonary venous hypertension, pulmonary congestion, occasional pulmonary edema, and all that. But there are some patients who do get frequent attacks of what is called as a bronchitis-like picture. And that is how we often pick up the mitosis in this manner. And there can be a reciprocal effect on the heart when you are treating with the infectious agent. We should be knowing about this. We do treat them with antibiotics. We do treat them with anti-inflammatory drugs. Some of them may have an effect on the heart itself. So it has to be understood about particularly on this interaction about these drugs also. For example, I will give you an example. A patient have a COPD or a bronchial asthma has got an associated heart disease. And if you give an sympathomimetic bronchodilators, we should be very careful because sympathomimetic drugs, they increase the heart rate, they can precipitate atrial fibrillation, they can make the palpitation in some of these patients who are being on an intensive course of bronchodilators. Similarly, there are some drugs which may be given for the heart. They may have an precipitating effect or an possibly in a field provided for the development of infections. Now, as far as the heart is concerned, is all the three layers. It's the pericardium, myocardium, endocardium may be involved. In the pericardium, it is manifested as pericarditis and or effusion. In the myocardium, it is manifested as myocardial many a times diffuse myocarditis. If it is a focal or sometimes if it is a regional, it may make a myocardial infarction. Endocardium involvement, we all of us know it very classical one is the so-called subacute bacterial endocarditis. And sometimes all the three layers are involved. As you have been listening in rheumatic carditis, it is the pericardium, myocardium, endocardium, all of them are involved. We call it as a pancarditis. So it may be a few layers or one layer, or it may be all the layers that may be affected. How do the infectious agent come here? It is by the contiguous spread. For example, if the patient has got a pneumonic patch, which is very adjacent to the heart pericardium, it may get spread. Some of the earlier tuberculosis infection did spread like that. It may be hematogenous spread coming through the bloodstream, and we should not feel too high above. Sometimes when we do a procedure like pericardiocentesis, even including a stent, we can introduce infection if we have not followed the proper antibacterial methods in the taking care of the patient, including patches when we do post-operatively, which we have used a Dacron patch or something like that. They can produce an infection and a bacterial infection which perpetuates, and it may even kill the patient. So some of the iatrogenic methods also should be kept in mind. What is more important in day-to-day practice, I will tell you, is that, for example, if a patient is an IHD patient with mild elevated function or an IHD without elevated function, just uh, with the infection-related tachycardia, infection-related changes in the blood volume, changes in the blood pressure, oxygen levels, including electrolytes, they themselves can worsen the heart disease. This is a very important thing. Just we should not think that the infection is there, infectious agent, it should directly affect the heart and produce the heart disease. No, it is an indirect effect. We should keep it in mind. A good astute physician should be able to recognize how much is contributed by the simple sinus tachycardia of the fever, or it is there is any change in the blood volume that is happening, particularly analyzing in terms of preload and afterloads, and oxygen levels and electrolytes should be kept in mind. Any infection which goes into the bloodstream, there is always a propensity for subacute bacterial endocarditis. In this lecture, I'm not going to dilate upon this topic because it itself is a very big topic to discuss about it. And there can be an infection on the walls, then can be infection on the damaged endocardium and the like, and the patient can develop a bacterial endocarditis. Much more than that, in the clinical practice, day-to-day practice, patient has developed an infection. He has been admitted for a pneumonia, or he has been admitted for some other GI tract infection. Patient goes on slipping down into that. Many a times we have seen that the patient's heart function is favorably fine when before admission. At the time of admission, we make out there is a mild LV dysfunction, and then slowly, as we go on, seeing the patient develops an relative hypovolemia, and there will be an widened pulse pressure, diastolic pressure falls down further, systolic pressure falls down further, develops a renal shutdown with or without paralytic ileus. What we call as a multi-organ dysfunction starts setting in, and we make a diagnosis. The patient may be having a septicemic shock, and what is happening in septicemic shock is more than the septicemic shock. The septicemia, it makes the cardiac to produce cardiac and as well as the GI tract to produce some endotoxins. Particularly GI tract produces endotoxins, which when they are circulating, come back into the circulation and depress the myocardial function. So septicemia perpetuates the cardiogenic shock like syndrome. So it leads one to the other. This is the commonest picture which we see. We should be able to know, recognize it, and manage the septicemia before happening, a shock state happening very aggressive in some of the patients. Now, coming back to the viral, bacterial, spirochetal, fungal, helminthic, whatever the infecting agents are there, which directly involve the heart. This is so far I spoke about indirect manifestation of the heart. Now let us try to look at the viral, bacterial, spirochetal, fungi, helminthic, protozoa, all of them can directly involve the heart. But in day-to-day practice, it is the viral organisms. In the viral organisms, we produce what is called as viral myocarditis. This is the commonest one. And in the few years, about 20 years back, we were talking about enteroviruses and Coxsackie viruses. But present for the last few 10 years or so, we are seeing more and more frequently herpes virus, parvoviruses, and equally all over the world, hepatitis C is a very important virus. Influenza viruses, depending upon the epidemics, is quite frequent. Corona is also one of the variants in that. We have had a very big epidemic recently, hardly 2, 3 years back, and that itself may involve the myocardium. The bacterial ones, of course, as I already spoke, sepsis, particularly mixed organisms, or it may be so-called gram-negative type of organisms. Every one of us know about diphtheria as we studied MBBS course. Diphtheria is predominantly Corynebacterium diphtheriae is an organism which produces an toxin, exotoxin, that is responsible for the myocardial depression. We do know that streptococcal infections as such can produce a carditis picture. Apart from what we all know about is the rheumatic fever, that is a post-streptococcal rheumatic involvement. Carditis is a part and parcel of it. A few years back, we were talking a lot about tuberculosis, which can involve earlier days, more of the time pericardium, pericardial effusion, slow, gradual infection or a burnt out infection producing a constrictive pericarditis. Miliary tuberculosis of the myocardium has been described in autopsy studies, but this miliary muscular involvement of tuberculosis has now become rare and rare. In fact, even the tuberculous effusions and constrictive pericarditis have become rarer. Whipple's disease is another disease again, which a bacterial infection can be produced. Spirochetal infections, Lyme's disease, is more common. Syphilis, but nowadays we don't see tertiary syphilis involving the myocardium, aorta, particularly aorta, and other places. Was such a common feature. But these have become basically theoretical things that should be understood, but rarely we do see them. We should keep it in mind. What is worldwide has been recognized is about Chagas disease. We should know about it. We need not be too critically about it that I don't know much about Chagas disease. It is a disease basically from South America. And here it goes through a peculiar cycle wherein the organism develops in the rabbits and sometimes the armadillos and from there from uh, the bugs, that transmit the disease to the human beings. And here, the first initial manifestation may be some skin manifestation, okay, what is called the Chagas complex. Then there will be an acute active carditis-like picture. Then it becomes more of a chronic dilated cardiomyopathy-like picture. This is, in fact, the large number of population in the South American variety. So we should keep it in mind. Carditis, if you are practicing in India, you don't think about it. But if you're practicing in international practice in say like South America and other places, you should keep it in mind, Chagas disease. Air travel has become too frequent now. Some of the patients may be traveling and coming over to us, and we should keep the common clinical manifestation how to make a diagnosis. And in India, there was another disease called as hydatid disease, was quite common. Trichinosis is also quite important disease. But the hydatid disease is very notorious. There are some areas where the hydatid disease used to manifest, usually asymptomatic cysts, and the cysts, if they bursting out into the myocardial cavity, it was getting spilled over and producing anaphylaxis. More of the time, they were seen as a curiosities by chest X-rays, nowadays by CT, and even including echocardiograms. And then we have to do operate these patients as early as possible to recognize, because as they grow, there is a chance they may rupture and produce the so-called anaphylactic reaction or a disseminated reaction. Now, as for the viral pathology or a bacterial pathology or any other infectious pathology, the infection is only presumption. We do have a clinical picture. We have some manifestations of the heart involvement, and we presume that it is an viral myocarditis, something like that. The difficulty is that so far our knowledge there has been a lacuna in our knowledge. Short of endomyocardial biopsy, you cannot prove or disprove a particular type of infection. Endomyocardial biopsy is basically an invasive procedure. It is not being practiced by everybody, and even there are too many false positive and false negative reports that are coming, because the biopsy specimens that we pick up are often from various areas, and there are some strict criteria that have been promulgated, what are called as the Dallas criteria, and strict histopathological characteristics should be there. There should be cellular death, that is the myocardial cellular death, as well as inflammation adjacent area. So many things are there. And now, since we don't do frequently endomyocardial biopsy, uh, the still, if you ask somebody asks, "Hey, how do you say this is a viral? Which viral? What viral disease?" If you say it's the bacterial myocarditis, what bacteria is affected? Have you shown bacteria in the myocardium? We do not, because we do fall short of doing endomyocardial biopsy, even in higher centers. Now, the viral myocarditis is the commonest one, as I was saying, is not such a frequent disease. The prevalence appears to be, if you take an heart failure patient, it is roughly less than 1% of the population. But we should remember it is not a simple disease. It can create a sudden cardiac death. I will give you simple, rough, approximate rules as from the literature that we have understood. About one third of the cases of viral myocarditis, they do run up to 6 months' time. They usually last up to 3 to 4 weeks sometimes, but once in a while, the patients can go on up to 6 months, and suddenly there will be an improvement in the clinical condition of the patient, and often the carditis completely disappearing and LV function improving normally. In one third of the cases, the viral myocarditis is a chance to recur. It is not only pericardial involvement, but even a myocardial involvement. They do often recurrence. So when we prognosticate to the patient or patient relatives, we should be very, very clear cut that there are some patients they may have to readmit with the same cardiac manifestation without our control. In about one third of the cases, the cardiacists may progress on to become dilated cardiomyopathy. Which are these cases? When exactly? After a period of 6 months, after a period of 1 year? It is difficult to say that. But the people are recognizing that roughly about 10% of the so-called dilated cardiomyopathy is the idiopathic variety, appear to be having a basis of burnt out viral myocarditis. In about one third of the cases, you can never make a diagnosis. I told you in the beginning the diagnosis is only an conjectural. So in about some cases, you will not be able to identify the virus in whatever methodology you adopt, and thus either you can prove or disprove the viral myocarditis. Some of the clinical features I'd like to highlight to you, because these are the very, very practical points. Many a times, viral myocarditis happens in young people, and there is often a clustering of the cases in a particular zone of the area. And when there is an epidemic, definitely when you make out a lot of patients coming to the with a non-specific chest pain or heart failure or cardiomegaly, you have to keep it in mind a possible myocarditis. And on the same basis, viral infections and bacterial infections, they can have a seasonal appearance, and they can be also have a geographical preponderance, as I said, in Chagas disease. And many a times the patients do have an associated manifestations at the time of carditis. Sometimes they may not be seen at the time of carditis. They may be preceded roughly about 1 to 3 weeks before the carditis manifestations happens in the form of fever, general malaise. There can be unexplainable chest pains, what we call the pleurodynia chest pains. There may be generalized body pains. So it is not exactly fitting into one particular system. You should, when you have this generalized complaints, even if it is a short duration fever with the body pains, one should keep it in mind in a case of a suspected carditis. Pericardial rub may be there. There may be just a cardiomegaly. Heart sounds become softened. There may be a third heart sound. Third heart sound is quite frequent in young people. It will not either exclude nor it will confirm your diagnosis. Apart from the carditis, there is often patients do have much more severe manifestations in the form of heart failure, and some of the patients may have only inappropriate tachycardia, bradycardia. There can be sudden death, as I said, apart from hypertrophic cardiomyopathy, ischemic heart disease, and many other cardiomyopathies, arrhythmogenic cardiomyopathies. We should also keep it in mind. Viral carditis is an important cause of sudden cardiac death. These are all small points which I am going to tell you already. I told many of the infections are there. For example, if you take 100 infection cases of influenza, you may see hardly about maybe 5 to 10% may have some manifestation of carditis. That means all infectious diseases will not end up in carditis. And out of this carditis also, very few will be having symptoms. Many of them will be asymptomatic disease. And they go unrecognized neither by the physician nor by the patient, and automatically will have a good salutary course. And some of these carditis are more the time self-limiting. There may be recurrence, and they can progress to dilated cardiomyopathy. You should keep it in mind. Many of the studies have shown that men are affected more common than the females, and the peak incidence is in the infancy and again in the children. Adults, it is not frequently seen. That is how it's got a bimodal occurrence. Within the 1 year, there's more frequent carditis, and after that, in the adolescent period, and again one more peak happening. But as a physician, we should suspect any deteriorating heart failure or a clinical manifestations of a heart failure or a heart dilatation in an immunocompromised patient having underlying cancer, immunosuppressant drugs, having an uncontrolled diabetes, and the like. When multiple comorbidities are there, it is quite a possible that you may have developed some of the manifestations of let me just talk about COVID. I think all of you know about it, and we have done a great job in India. We did invent and introduce the vaccine, and we could control the disease at a very early time. And in spite of it, that lot of patients died because of the lung involvement. There was an carditis involvement when they were coming after the discharge for our checkups. We did make out LV dysfunctions, LV dilatation. And more than that, in the post discharge time, we have recognized there is inappropriate tachycardia in some of the patients. And some patients, POT syndrome, that is postural hypotension, orthostatic hypotension, and tachycardia syndrome developing in young people. And they all had their own self-limiting causes. Some of them got benefited by the judicious use of beta blockers earlier stage. And now we are seeing another category of COVID that is out of the context of the present discussion in the form of the so-called long COVID. And occasional cases that we do see dilated cardiomyopathy, but most of them are of a burnt out lung diseases. How do you approach this sort of an infectious disease processes in a particular patient? The diagnostic approach is basically clinical. You have to take an ECG. ECG may show non-specific STT changes. You may have to take an X-ray. There may be a cardiomegaly. Cardiomegaly is much more prominent if there is an associated pericardial effusion. In a patient who has an associated respiratory infection, which has produced the cardiac involvement. Also, you may see a patch of pneumonia, either contiguous or non-contiguous in the lung X-ray. Echocardiogram is helpful in recognizing the LV dysfunction, which is often global type, global hypokinesia. Overall, LV function will be abnormal in these patients. Usually, simple viral myocarditis, just like in a rheumatic heart disease, you don't find an valvular involvement frequently. This is an important differentiating point. We should keep it in mind. And of course, now the most important investigation has turned out as an MRI. In places where it is possible to do these investigations, there are some peculiar way of distribution of the abnormality in the subendocardial area, which we can recognize the differentiate between the viral and the other diseases like sarcoidosis and even ischemic heart disease also. Again, I'm not going to highlight that. Now, there have been done some advances in this sort of infectious diseases, diagnosis, management, and other things. Basically, the advances that have taken place is in doing histological studies, both in histochemistry, immunofluorescence studies, immunohistochemical studies, complement fixing studies, and more higher centers have started recognizing viral genome studies, and that is how they recognize a possible viral carditis which has been missed clinically. And these are some of the investigations which are possible in only higher centers, but we should keep it in mind. These investigations are possible to hinge upon the diagnosis. Let me not go into the detail. As I said, if you don't want to have a cardiac involvement early when there is a systemic infection, you may have to use the antibiotic depending upon the type of organism that is affected. Viral organisms you don't have. There are some noise being made in terms of immunoprophylaxis and some amount of antiviral drugs and the like. But most of the time, prophylaxis is possible by giving an vaccination therapy. And of course, every one of you know about bacterial endocarditis prophylaxis. When there is a, particularly when you recognize there is a subtle valvular abnormality or a congenital abnormality, you feel like giving prophylaxis when the patient is undergoing an surgery, particularly involving the oral cavity, like dental and gingival surgeries. Again, I'm not going to highlight on this. What I am trying to say that is simple physician-wise approach of doing a prophylaxis for the in children vaccination for a diphtheria, recognizing the bacterial infections early, trying to give an influenza vaccination and a pneumococcal vaccination. And you should remember the pneumococcal vaccination and this thing, the influenza vaccinations, they not only will be helping in preventing the viral carditis, but more of the time, the secondary infections that happen in the elderly people, in heart failure patients, and multiple comorbidities above the age of 60, 65 years, we'll be doing a lot of service in the community prevention. And the treatment part, again, let me not highlight on that. Infectious agents should be used depending on the agent. There are people who are using modifying anti-inflammatory drugs, sometimes immunosuppressant drugs. And here it all depends upon the organism that is affected. So again, no much of detailed discussion about that. So I think it's a very interesting topic. Infectious disease is being talked less and less, but there are many diseases, both in the childhood and as well as the adulthood and beyond the adults in the above the age of 60, 65, various infections which can have both a direct and indirect impact on the heart. And the direct impact, viral myocarditis, particularly the most important one, but other organisms can also produce. But we should keep it in mind, particularly when we are seeing the patients suddenly in a location and depending upon the recent viral infections or throat infections and fever-like manifestations, one should keep them in mind. So thank you very much for your patient hearing. Any questions I'll be able to answer. Hello?
Thank you so much, sir. Thank you for such an amazing talk which you have presented in us and by putting across such interesting information about the topic. Thank you so much for that. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you.
Okay,
So the first question is related to the areas
sure.
of ongoing research. What are the key areas of ongoing research and clinical trials related to infectious diseases and the heart, and how might these developments impact future practice guidelines and treatment strategies?
Now, as far as the infectious agent is the most important disease entities we are dealing is atherosclerosis. There have been a lot of researches happening, but there it has been happening at the both at the molecular level and the cellular level. And there was a little upsurge in the investigations, connections being put for the gingival infections, and some even to the H. pylori infections also. Here and there, we do hear about and what is called as the gut-heart axis dysfunctions and so many things that are happening. And they're all fundamental researches that are happening. But to have an application knowledge, we have to really wait and see.
Thank you so much, sir. Thank you for answering that question. We will move to the next question, and the next question is related to diagnostics. So, what role do novel diagnostic tools such as multiplex PCR, assess, and molecular imaging techniques play in the early detection and characterization of infectious cardiac complications?
And that's a very important question, but I didn't highlight about it because I was thinking a general practice level, these investigations, discussion may be irrelevant, but it's a very important thing. They have been able to recognize, but the field is moving more on the genomic side. They have been recognizing the genomic markings in the endocardium and correlating with the viral infection. That is where the viral genomes, and that is where the infection process is going on. From the diagnostic point of view, myocardial involvement can have three distributions. One is the endocardial and subendocardial. It can have an mid-wall distribution, and it may have an epicardial distribution. And in this distribution also, it can have only a regional distribution or it may be a generalized distribution. So in that, you can do both a contrast enhancement or no enhancement. But there are some metabolic substances are also being given and then an MRI is being done. But that sort of a thing may not help because we are trying to look at a possible evidence of inflammation. Inflammatory cells part, we have to look into that. And the second point is the scarring. Scarring part, we have to look into that. Whether the molecular excessive intake that is being tagged on, I do not have much knowledge as far as the present carditis evaluation is concerned.
Thank you so much, sir. Thank you for answering that question. We will move to the next question. And the next question is related to patients. So, in patients with pre existing heart conditions, how does the presence of an underlying infection impact management decisions regarding medications, procedures, and lifestyle modification?
It's a very interesting point, actually. In fact, we see these problems more often in our day-to-day practice. And the patient is already a known IHD or a heart failure or a controlled heart failure, mild LV dysfunction. Suddenly they develop bronchitis. As an adult practitioner, my observation has been that there are more of the time lower respiratory infections that are the ones which often precipitate an acute coronary syndrome or an acute heart failure. And similarly, the patients who develop an pneumonic process, sometimes you may find it difficult to differentiate between the heart failure and the pneumonic process. That is, again, beyond the comprehension. But this is basically because of the tachycardia. A poor heart is not able to tolerate, will not be able to tolerate the higher heart rate because it increases the oxygen need, and also the diastolic part comes down, and the perfusion of the heart by the coronaries also suffers. Equally, the preload comes down because there is a relative hypovolemia. Afterload also changes. There is often the blood pressure falling and unrecognized hypoxia happens. For example, last few years back, whatever the corona epidemic we had seen hypoxia going up to the level of 50%. And that sort of a oxygen level can definitely not provide any oxygen to the heart. And they may, young hearts did it tolerate, but middle-aged heart didn't tolerate. Like this, there are multiple factors which are responsible for this worsening of the heart situation. Thus, instead of we referring these sort of cases, okay, you have an associated bronchitis, you go to the pulmonologist. Now you have a gastroenteritis, you go and have an endoscopy done by a gastroenterologist. We should try to manage them because your heart patient is yours. And some of these things, if you handle them earlier with whatever the knowledge of therapy is there, you will be doing a lot of service. And of course, choosing of the antibiotic or whatever it is, it should equally go by the simple common sense. For example, if an upper respiratory tract infection is there, an individual is having sneezing, some amount of throat discomfort, some amount of nose block, you know that it is probably viral, is it not? If there's a persistent fever and a sore throat, upper respiratory infection, you can use any of the bacterial, streptococcal, sensitive antibiotic, penicillin, or in some cases beyond penicillin also. The lower respiratory infections are most of the time H influenza. You have to choose the antibiotic accordingly. And sometimes in community, apart from community, patient was doing fine in the ICU. Second day, third day, he becomes a little feverish and cough and a heart patient. So you know that it may be an hospital acquired infection. You may have to give a blanket of multi organisms, is it not? Something like that. Okay. I don't want to highlight much about this thing. I'm just giving you a general aspect of how to take the antibiotics.
Thank
I
you so much.
hope I have
Yeah.
answered your question.
Yes,
Okay.
yes, yeah, I was about to say that. Thank you so much, sir. Thank you for answering the questions for all our viewers and for making them understand about the topic in such a better manner. This was the last question for today's session, and I would like to thank you and all the viewers who have been an ardent participants and for staying tuned throughout the session with us. And I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with us, sir. Thank you so much, sir.
Thank you. Thank you very much. Wish you all the best time. I
Thank you so
think
much, sir.
Ugadi festival is also coming. I will wish you all in advance. Okay.
Thank you. Thank you so much, sir. So, with this, we are concluding the session here for today. Until next time. Thank you,
Thank
sir.
you. Thank you.